Welcome to today's Explainer. Let's just dive right in, shall we? Today we're tackling a clinical question that I know comes up on the neurology floors and in the ED literally every single day. How do we optimally balance efficacy and safety when prescribing clopidogrel plus aspirin for secondary stroke prevention? We're going to put the data side by side to see how the differing methodologies of the landmark CHANCE and POINT trials actually give us the exact blueprint for the optimal dual antiplatelet therapeutic window.
Here's our roadmap for today. First, the dual antiplatelet question. Then, comparing trial methods, followed by primary efficacy outcomes and primary safety outcomes. Finally, we'll synthesize the results and cover the key clinical implications.
Section 1. The dual antiplatelet question. So let's briefly frame the urgency here. As we all know, the risk of a recurrent ischemic stroke is remarkably high. We're talking anywhere from 3 to 15% in that crucial 90-day window right after a minor ischemic stroke or a TIA. And most of these recurrences, they happen very early, often within the first 48 hours. Now, monotherapy with aspirin knocks that risk down by about 20%. But the big question driving both of these trials was simply, can we do better in that acute high-risk window? Enter clopidogrel. It targets the P2Y12 receptor pathway, and when you combine that with aspirin's classic COX-1 inhibition, you get this really potent, synergistic block of platelet aggregation. We already knew this combo worked beautifully in acute coronary syndromes, right? But the pressing question was whether this synergistic blockade could safely translate over to the cerebral vasculature without causing, unacceptable rates of intracranial or systemic hemorrhage.
Moving to Section 2, Comparing Trial Methods.
Let's look at the methodologies side by side. The 2013 CHANCE trial enrolled a strictly Chinese cohort, used a 300 milligram loading dose of clopidogrel, and, crucially, this is the big one, they limited the dual antiplatelet therapy, or DAPT, to just 21 days before stepping down to clopidogrel monotherapy. Fast forward to the 2018 POINT trial. The investigators here wanted to test this in an international cohort to boost generalizability, but notice the shifts in methodology. POINT used a higher 600 milligram loading dose of clopidogrel, and they pushed the DAPT duration out to a full 90 days. Keep that 21-day versus 90-day duration in the back of your mind, because it perfectly sets up the data we're about to see.
Section 3. Primary efficacy outcomes. Both of these trials were obviously hunting for early ischemic benefit, and the numbers brilliantly illustrate just how successful the CHANCE trial was. They hit a highly impressive hazard ratio of 0.68 for stroke recurrence at 90 days, with a p-value of less than 0.001. To put that in absolute terms, stroke occurred in 8.2% of the dual therapy group, compared to 11.7% in the aspirin alone group. This was a massive win for early aggressive platelet inhibition in the acute minor stroke and TIA population. And then, right on its heels, the POINT trial delivered highly consistent efficacy data showing a 0.75 hazard ratio for major ischemic events. They saw events in 5.0% of the DAPT group versus 6.5% in the aspirin group. So the bottom line, both trial designs definitively prove the primary hypothesis. Combination antiplatelet therapy absolutely provides superior early ischemic protection compared to just using aspirin alone.
Section 4. Primary safety outcomes.
But as we know, efficacy is only half the story here. Looking at the CHANCE safety profile, limiting DAPT to just 21 days paid off safely. Moderate to severe bleeding occurred in exactly 0.3% of the clopidogrel aspirin group and 0.3% of the aspirin-only group. There was literally zero increased risk of major bleeding. That short duration and maybe that lower 300 milligram loading dose seemingly threaded the needle perfectly between efficacy and safety. However, if we look at the safety curve from the POINT trial, we see a crucial shift. Because POINT extended DAPT to 90 days, you can see how the hemorrhagic risk just continued to climb as the trial progressed. Major hemorrhage occurred in 0.9% of the DAPT group versus 0.4% in the aspirin group. That's a hazard ratio of 2.32. In fact, the POINT Data Safety Monitoring Board actually halted the trial early because this signal for major hemorrhage crossed their pre-specified boundaries. The bleeding risk clearly accumulated over that extended 90-day period. So what does this all mean for us? The central dilemma for us as clinicians is really this. How do we balance that clear, early ischemic protection with a hemorrhagic risk that clearly keeps accumulating over time?
Section 5. Synthesizing the results.
First off, we've got to acknowledge that the efficacy is both real and incredibly broad. The forest plot from POINT shows that the ischemic benefit is robust across all sorts of diverse international patient subgroups. There were no significant interactions based on age, sex, race, or whether the index event was a minor stroke or a TIA.
The underlying biological mechanism holds up universally.
But here is the real kicker. The timeline is everything. A time period analysis from the POINT trial brilliantly synthesized this whole dynamic. It showed that the ischemic benefit of clopidogrel plus aspirin was vastly concentrated in the first 7 to 30 days. However, the risk of hemorrhage, that remained constant and actively accumulated from day 8 all the way through day 90. Basically, prolonged dual antiplatelet therapy beyond that first month yields severely diminishing returns. You stop preventing strokes at a high rate, but you just keep causing bleeds. This essentially completely validates the brilliant 21-day design of the earlier CHANCE trial.
Section 6. Key clinical implications.
So, how do we actually take hundreds of pages of trial data from CHANCE and POINT and apply them to the patient sitting in front of us today? Here is an actionable, rapid-fire clinical protocol synthesized directly from both landmark trials. Number 1, initiate therapy rapidly. Both trials required randomization within 12 to 24 hours of symptom onset. The ischemic risk is heavily front-loaded, so our treatment needs to be as well. Number 2, limit DAPT to the first 21 to 30 days. This maximizes the ischemic benefit while completely cutting off the tail of that accumulating bleeding risk. Number 3, patient selection is absolutely key. Target minor strokes, meaning an NIHSS of 3 or less, or high-risk TIAs with an ABCD2 score of 4 or higher. And finally, number 4, know exactly who to exclude. These trials specifically excluded patients with presumed cardioembolic sources who obviously require full anticoagulation and those with moderate to severe strokes where the baseline risk of hemorrhagic conversion is already just too high. Looking ahead, a really fascinating question emerges from the discussion sections of these papers. We know that polymorphisms in the CYP2C19 gene, which are especially common in Asian populations, can lead to poor clopidogrel metabolism. So as we continue to refine this 21 to 30-day window, will rapid genetic profiling become the standard of care in the emergency setting to truly personalize these acute antiplatelet regimens? Maybe for poor metabolizers, we'll be looking toward alternatives like ticagrelor in the future. It's an incredibly exciting frontier for precision stroke care. Thanks so much for joining me for this explainer. I hope this synthesis brings absolute clarity to your next clinical shift.